Hi, folks. I'm Bob Schrupp, physical therapist.
Brad Heineck, physical therapist.
Together we are the most famous physical therapists on the internet.
In our opinion, of course, Bob.
Today, Brad, we're going to talk about anterior hip approach, the procedure, the precautions, the exercise, all of it. We're going to talk about it all.
So anterior hip replacement, and so they call that approach, because you can come from the front side or the back side, and we're talking about the front, which is anterior.
Which is less common, much less common, right? Like 1% of the maybe.
Well, I'm not sure about that, but I think it's one of those things that's going to start changing, and you'll find out why with this video, and we're going to do another one on the posterior approach.
Sure.
And so anyways, shall we carry on?
Yeah, well, if someone is new to our channel, by the way, please take a second to subscribe to us. We provide videos on stay healthy, fit,
I think that
pain-free.
person was here before, but there's more coming behind.
All right, that's good. And we upload every day. We have a subscription button here and here. Ooh. And also, if you have a chance, wander over to Facebook and like us, because I know I'm well liked, but Brad is really concerned that he isn't. So
yeah, so at least like for me, you know, you don't have to like Bob.
Yeah, I'm already there, I guess. So okay, let's get started, Brad.
Okay, the hip. So the hip, like I said, we need to get to the hip joint, and here we've got Napoleon laying down so we can get a better view.
Napoleon Bonaparte.
There you go. So the hip is actually, you know, it's the socket, the ball and socket here. A lot of times people think the hip is that bone you feel up here. Yep.
And there's the socket.
Right. So you got to get to this, and they literally have to take the ball out, which is also usually decayed from arthritis, and they cut this off, and they're going to put in a new what they call prosthesis. This is typically metal. That goes in, and there's actually a long leg that goes down into the bone, and they cement it in typically.
Is it titanium or metal?
I think it's titanium. Yeah. Whatever, it doesn't rust.
It's titanium a kind of metal? I don't even know anything about it.
Yeah.
It's okay.
Yeah. I haven't looked at my metallurgy yet, Bob, but I probably should have for this video. And then, of course, the acetabulum, or the cup, they actually remove that. Sometimes they can just do just the ball and they'll leave the socket. That's a
hemiarthroplasty.
Exactly.
Yep.
Otherwise, they'll take this out, and this is amazing. I'd like to see this. I haven't had a chance to do it yet. How they remove the socket and put a new, it is typically a plastic type of plastic in there, and they cement that in there, because as soon as the surgery is done with, you can get up and bear 100% weight.
Yeah, that once, because I mean, I did observe a surgery 30 years ago, and at that time even already, the glue was solid immediately. Mm-hmm. I mean, once it was in place, it was as hard as it was going to be.
Right, right.
So
yeah, I saw a knee, and they used a putty. I think it was a 2-part putty. He had to mix it together, and it was like Play-Doh.
They gave me some of it, and it starts heating up in your hand.
Oh,
it gets really hot.
Yeah,
so
exothermic, I believe that's called.
There we go. Nice.
Chemistry's paying off for me.
Yeah.
So anyways, the question is how do you do this? And do you come from the front and replace it, or you come from the back side, which is actually going to cut right through your gluteus maximus muscle, which is a large muscle, and they have to open that open to get it in and do the replacement. Well, we're going to talk about the anterior approach and the advantages of the anterior approach. So, first of all, one of the disadvantages of the anterior approach is they need a special operating table.
Yep.
And
I had a friend that just went through this, and they were doing the first one on him at our hospital here.
Yeah.
And he waited for months. They were ordering this special table.
Sure.
And so.
From my understanding, I have not seen one, but I've been told about it at continuing ed class. One thing that's special about it, the person lays on their back versus on their side, and the table has to break loose so they can you keep Napoleon like this? So that you can drop this leg down, and then they open it up so they have room to get in to do the operation.
Gotcha.
So you can imagine the table's not just a solid one; it has to break, and it has to break with obviously good control.
To adjust in a certain way.
I don't know what one of these costs, one of these tables, but I have a feeling it's probably.
Oh, they're very expensive.
Many thousands, maybe 100,000 of something of that nature.
I think it was many thousands.
And that's why I think as more hospitals buy this table, they're going to be doing more of them.
Right.
They're not going to buy it for one surgery.
The other thing to keep in mind is a lot of surgeons haven't done a lot of these. Maybe some have, but this surgeon that my friend was using had only done one.
Sure, right.
So,
he will do more, I
yeah,
imagine.
he will do more, but
Okay, the advantages is there's much less tissues to cut through. Like I said, on the backside, you have a lot of muscle.
Going through that heavy
Yep,
gluteus.
and you're going through much more. And here, it's less tissue to cut through, less damage. The disadvantage, it's more complicated. And I don't know, I'm not a surgeon, I haven't,
Right.
but from the information I have, it's more complicated. You know, you got an artery, you got a
nerve artery,
yeah,
vein.
femoral artery,
Yeah.
and tissues. And then again, from the surgeon that I did do some research on, and this particular surgeon liked posterior better. He said it's harder, it's a smaller area to get into. You got this bone here, and you open this up, and you have a corner to get around, and it's just a little more complicated that way, just going along with more complicated surgery. But once it's all said and done, you know, and they're clearly getting better at these, I believe, and that's why they weren't doing them initially, because you know, they didn't have the tools and the technology, but now they're getting better and likely will do more. The big benefit is for the patient, I think, and that is the precautions.
Right.
One surgeon said he lets them go with no precautions, lets them do what they want, but typically from the surgeons that I've worked with, they spell it out and it's always the same precautions.
Right.
But one way or another, talk to your surgeon, get the precautions from the surgeon or his assistant.
So generally a lot less precautions
Right,
after the anterior.
right.
It tends to be a lot less likely to dislocate, especially if you're going to be real active, and that's why my friend got it.
Sure.
Because he skis.
Sure.
And he was worried that the way he skis, cross-country skis,
Yep.
or that it was going to actually, you know, dislocate while he
Sure.
was doing it.
Well,
So-
the stats I saw was 10 times less likely to dislocate with an anterior versus posterior.
Wow.
Not that many posterior dislocate anyways. I mean, that's pretty low, but this
Right.
is even much lower.
But you touched on a good point, though, Brad. Every surgeon is different, so you need to find out what your surgeon wants.
Exactly.
Because they're always, I mean, when I was at a hospital, they actually had all 10 surgeons listed down and what their precautions were for each
Sure.
one. And they're all
Yep.
different.
Yep.
So-
Exactly.
So-
But typically, anterior precautions are you're not going to bring the hip back like this. You
Right.
don't want to extend it or go back like this. You know, because what that does is you have the surgery here, you're spreading open all the tissues they just cut through and they need to heal up.
Brad, do you want to show real quickly that you shouldn't do that laying down then either?
You
know,
mean
prone?
a prone?
Yeah.
Yep. Yeah. So the other thing is before we do that, you don't want to turn your leg out like
Sure.
this. Externally rotate, because when you do that, that opens up this way the tissues in there, and that pulls on that surgical site. These typically will be removed after a certain amount of time, usually
Yeah.
a few months. Again, get that information from your surgeon.
What Brad's saying, that after like 6 months or 3 months maybe, you won't have any precautions at all.
Exactly. Yep.
So-
Get on with life.
So
So laying down on your stomach, you don't want to do it because if you go up like this, that also stresses that.
if you
front
get up to
part.
get out of bed, look at that, you know, as you're getting
Yeah,
out of bed.
Exactly. You know, I wasn't even thinking about that, and a good point, Bob.
And a lot of times people do exercises for their back that way, so you
Right.
can't be doing those right
Right.
now either. So
Recovery time is typically faster with an anterior. You get to higher level activities like with your friend. As a matter of fact, one doctor I saw was looking at 6 to 8 weeks back to playing tennis.
wow.
Yeah, but he said it can vary quite a bit. That
Sure.
was unusual.
Sure.
But still.
Again, to me, one of my concerns would be to try to find someone who's got the experience that has done quite a few of these. 'Cause
Right.
I wouldn't want to like to go into one where somebody's only done one.
Right, exactly. So
so-
do your homework on these. That's why you're watching this. As far as afterwards exercises when you go home, there's no real particular ones, but we're going to show you what typically the therapist will be showing people. And you're going to have your walker, you know, after surgery because you might be a little unsteady. You're going to be holding on something for balance. But, you know, simple hip flexion.
Sure.
And you're going to do it as tolerated. It might be a little sore after surgery, so you're not going to push it into sharp pain, you know, as
You
tolerated.
can hold on to a countertop too. if
Sure,
you-
yep. Good point. Can you get me back here, Lonnie? Yep. So I'm going to hold here, but so you can see a profile, it'd be the countertop would be here. You do your marches, you know, 10 on a leg. There's going to be a little sore on the involved leg, obviously. An important one is hip abduction out to the side. Bob, you want to point to my toe?
Sure.
You
See how his
don't-
toe, yeah, you don't want it turned out like that.
Right. The toe is straight.
Yeah, there you go.
The natural tendency is to do this.
Right.
If you don't think about it. So this takes a little thought for most people. Okay.
Brad, do you want to show too how it's really important not to stand on that leg and then pivot?
Exactly.
Yeah.
Good point, Bob.
So-
Let's say I'm into the point of my rehab where I'm walking around. You could be walking or your cane. This would be the involved hip. If I keep my foot planted on the floor and I turn my body this way while it stays planted,
He's turning the hip out.
right, that puts stress on that anterior part of the hip where the surgery is.
When I've seen people dislocate hips, and I've had, we've had many, a lot of them where it had some dementia involved.
Sure.
One was in bed, and two was that way. Standing and putting weight on the hip and pivoting.
At the same time.
Yeah, at the same time.
Right. So this is anterior. You don't want to go this way. Posterior.
You don't want to go that way.
You don't want to go that way.
Yeah.
So for this video, it's anterior. You're gonna, if this is the involved leg.
I wouldn't want to pivot on that leg no matter what.
Right. Exactly.
Start off.
Sure. Just don't pivot.
Always pick it up. Yep. Do the little steps.
You're gonna be dancing.
Yeah.
Okay. Good point, Bob. Be safe. Better to be safe to the sorry.
Yeah.
Okay.
So hip flexion, hip abduction. Anything else, Brad?
You're not going to do hip extension,
Right.
which you do with the posterior
Right.
approach. Okay, and you certainly can do squats.
Sure.
And a big advantage is you can sit down, bend over, and put your shoes on, which is
Right.
a big no-no.
On the other one.
On the posterior
They
approach.
spend a lot of time on
Yeah,
that.
there's a lot less to think about with the anterior approach as far as the patient and range of motion. The two we
Right.
mentioned are important, but most people don't do those anyways.
Right.
Everyone bends forward to get
Yes,
dressed.
or to do other things.
Right,
I mean,
exactly.
It's just a hard habit to
Exactly.
break.
So,
You just had heel toe ups, Brad? Or
oh,
you gonna do
sure,
those
good
just
one for
standing?
balance again.
Yeah.
Here, you're gonna
So
rock.
we're way down here, looking down here.
Yep. And that, that's
and
one of
holding
those.
on to something.
Yep, holding on to something, because you'll be amazed if you do it try to balance on one leg, the leg that didn't have surgery, oh, that's normal. And then the other leg, even though it feels pretty good, chances are you're going to be all over the
Yeah.
place. So you got to regain that proprioception and balance.
We're trying to gain the strength all the way up down the limb.
Yep,
So,
from top to bottom,
yeah,
exactly.
so.
Wow, Bob.
All right, remember, Brad, we're not just helpful.
Oh, sure, you
we're not
threw
just
me off.
pretty.
Yeah, we're pretty ugly, doggone it.
I totally screwed that up.
Yeah,
The line is,
that happens, though,
remember,
Bob.
Brad and I are not just pretty,
We're pretty
ugly, but we say we're pretty handy too.
Handy.
And helpful.
Yeah,
So-
as a matter of fact, we used some duct tape just 5 minutes ago on that chair.
Yeah, we did, right underneath. So, thanks for watching.